sessions which we're having for our fellows. So this time we have chosen non-transfusion dependent thalassemia as our topic. And I'll now hand over to Dr. Vandana Bharadwaj, who's moderating all these sessions, to start the session. Dr. Vandana, please.
Thank you, ma'am. Welcome to the second session of the second edition of online teaching program of the IAPPHO. It's a pleasure to welcome you all, and it's wonderful to see the response. We have nearly 60 participants at the start of the session. It gives me great pleasure to welcome Dr. Vibha and her team from Bharati Vidyapeeth University at Pune to the start of this session. So Dr. Vibha is a senior consultant and in charge of the IAPPHO fellowship at Bharati Vidyapeeth, and she will be doing the second part of the session, which is the approach to NTDT and differentials and some investigations. Welcome Dr. Revati, who's a junior faculty at Bharati Vidyapeeth, recently joined, completed her fellowship and has been working at Hyderabad for a few months before moving to Pune recently. So welcome Revati. I know you're not a student, but welcome regardless. We don't bite here on this forum, so you're in very safe hands. It's just for you to present and just as a lead pad to move the session forward. So Dr. Revati will present a case first, and we will talk about relevant issues and some investigations, approach, differential diagnosis with Dr. Vibha. And then we'll go to an expert session on management and new frontiers from Dr. Shruti Kakkar, who needs no introduction to this audience. She's associate professor and in charge of the pediatric hemonc unit at Dayanand Medical College in Ludhiana. Welcome, Shruti. Nice to see you again. So we will hear from Shruti later on in the evening. So first of all, Dr. Revati from Pune, the floor is yours. So Revati, are you here and can you share the slides? So Revati, are you here? Can you hear us and can you put up your slides?
Can you hear?
Yes, we can. A little bit faintly, but we can.
Huh? What happened?
She's not audible, Dr. Revati.
Yeah, I don't know. She has called me. I think she's not able to do it.
Even Dr. Vibha, even you're not very well audible. Dr. Vandana will have to.
Hello.
Dr. Vandana is very easily audible.
Hello, is this better?
Yeah. Revati, we can hear you now.
No, this is me, Vibha.
Oh, this is Vibha. Sorry, Vibha. Yes, we can hear you well. No problem.
So Revati can, I don't know. She's there.
Yeah, I have.
Yeah. Okay, excellent. Can see you.
All right,
nice.
Good. Now Revati.
Okay.
Shall I start, ma'am?
Yes, you can start. All introductions are done. We welcomed and introduced you in your absence.
Sorry for there were some network issues, I guess, ma'am.
No worries. We're only on 7.7. It's absolutely fine. Please go ahead, share your screen and start.
Okay, ma'am.
Requesting all others, trainees and faculty, to kindly switch off your videos and mute yourselves for the rest of the talk. Thank you very much.
Can you see the slides? Are the slides coming?
No.
Not yet.
Just give me a second, no?
Sure, sure. Requesting all others to kindly mute yourselves and switch off your videos.
Post disabled participant screen sharing. Disabled. Just
It is coming host disabled participant screen sharing.
Hi, Vibha.
Anukriti, are you there?
Yes, ma'am.
Anukriti, are you there? Could you please?
Is there someone from ECHO team that can please help?
Yeah. So the Anukriti who has hosted the session, she can just change the settings. I won't be able to do that.
Okay, is she here?
Yeah, sure, she's here, but she's not responding.
Can
You just check. Yeah, you just check, ma'am, again, Dr. Revati. You just check if you can do now.
Yes, I'm doing it again.
And I request all the participants to turn on the videos for the better interaction. We would keep all the participants on mute so that there is no disturbance during the session. But yeah, we would encourage you all to put on your videos. Thank you.
Slides visible now?
Is it visible now?
Yeah, your
Yes,
desktop
ma'am,
is visible. Yeah.
full screen.
How?
Like just do it.
Is it visible?
Yes, ma'am, it is visible. Please put it in the slideshow.
Revati, you'll have to stop all that, put a click on the ones on the side and then go on to the slideshow. So the full slide is visible, okay? Otherwise, we only see a tiny slide.
Somehow it is not coming. Shall I start the presentation?
Yes,
Ma'am,
I
please
think
press
so.
F5 on your desktop. Has it changed?
No, it is not.
All right, okay. You carry on.
Right lower corner.
Shall I start?
Do you want to mail it to somebody else?
Yes.
Dr. Revati, can you put the tiny slides outline? There's a little cross over there. Can you cross that so that that switches off that slide, the little ones? And also the PowerPoint one in which you've written for the recovery, if you put that off, your slide size will automatically increase. So that will make it easier for everyone, even if you cannot go onto the slideshow. Or increase the percentage of the screen which is being shared, that will make it easier.
If they show in the slide setting, they can change its setting. Window sharing. Then it will be possible to share the PPT.
Yes, yes, you're right. That's what I was trying to explain to her. She puts that on. Yes, perfect. Now you can start. Perfect.
Excellent. Well done.
Sorry for the delay. Good evening, one and all. I would like to start with the case presentation. A 14-year-old girl hailing from Rajasthan, born to non-consanguineous married couple, second in order, belonging to Chaudhary community. Child presented 4 years back. At the time of presentation, child was 10 years old. Parents had noticed progressive pallor, was evaluated elsewhere, and was referred for further workup for pallor to our center. There was no history of previous blood transfusion, no history of similar illness in the family. On examination, pallor was present, there was hepatosplenomegaly, there was no lymphadenopathy. Investigations which were done during the initial evaluation, the CBC showed HB of 7, total counts were 8,600, and platelets was 4,60,000. The RBC was 3.14 millions per cubic millimeter. MCV was low, which was 70. MCH was 22, which was low. MCHC was 32, and RDW was 35. The reti count was 6, and the corrected reti count was 3.6. So the peripheral smear showed microcytic hypochromic picture with anisopoikilocytosis, teardrop cells, pencil cells, target cells, few spherocytes, and 15 NRBCs per WBCs were seen. The peripheral neutrophils showed mild shift to the left. Platelets are adequate in number. Serum ferritin was 98.3, the TSH was 2.98, and the HPLC report showed increased in the HPF, which was 76.3, which was suggestive of beta thalassemia homozygous. And the parents and the siblings, HPLC was not done as they were not willing at that point of time. USG abdomen showed hepatosplenomegaly, liver of 11 centimeters and spleen of 13 centimeters. Child was diagnosed as non-transfusion dependent thalassemia and was planned to be started on hydroxyurea and folic acid. So the key diagnostic points in our case was anemia with hepatosplenomegaly, late onset of presentation, no requirement of blood transfusion since birth, low MCV and MCH, NRBCs in the smear, and HPLC suggestive of beta thalassemia homozygous. So the child was lost to follow up with us for 4 years. So the child presented again now with not gaining height and not attaining menarche. She had generalized lethargy. So she was neither on any medications nor received transfusion in the past 4 years. So on general examination, we found pallor. There was mild hemolytic facies. There's mild depression of the nasal bridge and mild prominence of the cheekbones. And there was short stature. So the growth and the sexual development of the child, the height was 138 centimeters, which was coming below the 3rd centile. And the weight was 32 kgs, which was below the 10th centile. And the sexual development was Tanner's stage 2. So this is the growth chart showing the height less than 3rd centile. On systemic examination, there was a liver, which was palpable 3 centimeters below the right costal margin, spleen palpable 5 centimeters below the left costal margin. So the recent evaluation which was done showed CBC of 8.6, HB of 8.6, total counts 4,500, 1.8 lakh was the platelets, and RBC was 4.07 million per cubic millimeter. And the serum ferritin was 234 nanogram per milliliters. So USG abdomen showed spleen measuring 15.3 centimeters, and there was no calculi in the gallbladder. The serology was negative. So the endocrine evaluation was done for this child. Thyroid function test was normal. Estradiol was less, which was 17. LH and FSH was not detectable. IGF-1 was decreased, which was 65. The fasting blood sugars were normal. The bone age assessment had 3 years of growth potential. So the current issues in this child is short stature and delayed puberty. So the further plan for this child would be to plan for a molecular workup, to do a RBC extended phenotyping before the transfusion, and to start on a chronic transfusion therapy in view of growth retardation, delayed sexual development till she attains normal growth and menarche, to get a bone density scan, to monitor her growth and sexual development, and to have a regular follow-up with the endocrinologist. Thank you. So I'm ending my case with the further plan for the child.
Thank you, Dr. Revati.
Thank you.
And if you could stop sharing your screen.
Yes.
So this is a good sort of leap pad, a session to just launch into how to approach a patient like this. This is something that we don't see too frequently, not the usual transfusion-dependent thalassemia, but a slightly different phenotype. And we've already seen what some of the problems could be. Over now to Dr. Vibha to expand on approach differentials investigations. Dr. Vibha.
Thank you, Vandana, for that. Thank you, Revati, for the extremely good case presentation. So here, this child was in fact 4 years back seen by me. And at that point of time, she was growing well. She was okay. And then she was lost to follow-up, unfortunately. The COVID happened. Again, she came back. She was obviously not growing well. And she was failing puberty. We had an endocrinologist take her up, and we concurred that we should put her on a regular blood transfusion for her growth and for her pivotal listing. So can I share my screen?
Revati, you probably need to stop sharing your screen first. Stop sharing your screen. Yeah, you should be able to do it now, Dr. Vibha.
Can you see my screen?
Yes, we can. Probably just need to go to slideshow.
Is it all right?
No, it's still in the normal mode with the outline on the sides. Probably need to go to slideshow on the top and play.
No, because my screen is showing that it is on slideshow.
Ah, okay. We are not able.
Okay, then you just continue like this, I think.
Is this okay?
Because
are my
yeah,
slides moving? Are my slides moving?
No,
it's on the path.
No. That's not.
It's on number 20 actually. So
I know.
it's not
on my screen, it is showing on the first slide. So shall I stop share and do it all over again?
Yes, please.
Is this better now? Is it seen now?
Yes, ma'am, it's fine now.
Slides are not moving. Are the slides moving? Is it full screen now?
Yes, yes, slides are
Yes.
moving and it's full screen, so you
Okay,
can
thank you
go.
so much. Thanks for the technology. Sorry for the technology glitch. So basically, we know that non-transfusion dependent thalassemia patients, they do not require lifelong regular transfusions for survival, just as a thalassemia major, but they may require transfusions for some well-defined periods of time. This may be occasional, that is sometimes when they have infections, or they may need to be put on a regular transfusion for some set clinical conditions. So, as we know that this NTDT or thalassemia intermedia, it's a totally clinical phenotype. What are the genetic phenotypes which present like this? So we have three very well-defined genetic phenotypes, which is first is the beta thalassemia intermedia, then you have HBE beta thalassemia, and then there is alpha thalassemia intermedia, that is also known as HBH disease. The other ones, that is the HBS and HBC with thalassemias, may also present like this, but then they also have some distinct clinical characteristics, and we will not be discussing that today. So coming on to epidemiology, the entire hemoglobinopathies, as we all know, they exist in the low or middle income countries in the tropical belt. They stretch right from sub-Saharan Africa in the west to the Mediterranean countries to the south and the Southeast Asia. So we can see the middle of the world, the tropical belt, is the hot seat for hemoglobinopathies. And the beta thalassemia is one of the common ones. 1.5% of the global population are carriers, and 23,000 children are born with thalassemia major in the world. The NTDT form is not well defined. Even world over, we don't have very good data about it. But then, ill-defined number of these 23,000 will have the NTDT form. As is very obvious, the population which will have a high frequency of the carriers will also have this form. Coming on to the HBE thalassemia, the HBE mutation is found in the eastern part of the world. Even in India, it is found commonly in the northeast states. Then coming on to the other eastern countries like Thailand, Laos, etc. And it affects a huge population worldwide. The HBE beta thalassemia, almost 19,000 children are born with this condition. Half of them will have the transfusion dependent form, and the other half will have the mild and moderate forms, which can present as non-transfusion dependent thalassemia. Coming on to alpha thalassemia, it is the commonest mutation worldwide. Approximately 5% of the world population carry this mutation, and more than 1 million patients are affected. As we all know that the alpha thalassemia major, that is your HB parts, is not compatible with life. So it is the HBH disease, which is where 3 genes are deleted. That is the common form of alpha thalassemia. It's also known as HBH, and it presents as a non-transfusion dependent. But then it is estimated that maybe 10,000 children are born with this, but this estimation can be very incorrect, because to diagnose alpha thalassemia, you need genetic studies, and which is not easily available. Even today, it is still costly and not easily available except in the major metros. In India, so India has a distinction of having the largest number of children with thalassemia major. About 3 to 4% of Indian population are carriers, and approximately 10 to 15,000 of children with thalassemia major are born every year. As we know, there is not much data that how many of these are NTDTs. So the same population will have that will have thalassemia major will also have the NTDT form. In India, as we know that there are certain communities which have a very high incidence of thalassemia major. In the north, it can be the Sindhis, Punjabis, Khatris. In our state of Maharashtra, we have the Mahars, Kolis, Agris. Down south, we have the Reddis, Gaudas. HBE, as I said, is common in the northeastern states, and we can have a carrier frequency as high as 50%. This is the Indian map, and it is there in this Ministry of Health, Family Welfare write-up. It is showing the incidence of the major hemoglobinopathies. And as we can see that the thalassemia incidence is very high in the northern part of our country. So what is it that makes the phenotype milder compared to thalassemia major? So there has to be a genotype-phenotype association. These associations can be divided into three parts. There are the primary modifier associations. So the primary modifier for beta thalassemia intermedia is the mutations that cause the beta thalassemia. So as we all know, more than 200 mutations have been described, which can manifest in the homozygous or compound heterozygous forms. So these mutations can be very mild mutations, the promoter mutations, which just decrease the production of beta thalassemia, the beta globin chain by a very small percentage, ranging on to very severe mutations, which can lead to a complete absence of beta globin chain synthesis. As we all know, it is ultimately the alpha beta chain imbalance which causes the ineffective erythropoiesis, extramedullary hematopoiesis, and that leads to the phenotype of thalassemia. So these diversity of mutations will ultimately affect the alpha beta globin chain imbalance. Coming on to the secondary modifiers, the secondary modifiers are conditions which affects this imbalance. So for example, if you have co-inheritance of different molecular forms of alpha thalassemia, so this will lead in the decreased production of alpha chains, which will lead to decreased imbalance. So a child who may have manifested as major will now manifest as an intermediate. Similarly, you may have increased expression of the alpha hemoglobin stabilizing protein. Then there is this interesting condition where mutations which lead to increased production of gamma chains. So then you can have the, if the gamma chains are increased, then the alpha chains will bind with gamma chains to form the HbF. The HbF will increase, and this will ameliorate the condition of thalassemia major to an intermediate. And you know that these mutations are found on the beta globin gene cluster itself, the gamma delta mutations, and you can also have them on the different chromosomes. So the tertiary modifiers are polymorphisms which are not related to globin chain production, but they may have ameliorating effect because they affect things like iron absorption, delivery metabolism, bone. And then you can have conditions, for example, if you have a triplicated or quadruplicated alpha genotype, so a patient would have presented as a thalassemia trait, but then he has a triplicated alpha gene, which will again lead to a alpha beta globin chain imbalance, leading to a intermediate phenotype rather than a trait. And then there is a very rare condition known as a dominantly inherited thalassemia major, thalassemia, in which one gene locus is normal, but only one is affected, but that causes severely decreased production of alpha chains and leads to a thalassemia intermedia-like phenotype. So this is the genotype-phenotype association in beta thalassemia, which I just described, and this is giving all the different kind of genotypic manifestations possible, leading to a milder presentation of thalassemia. Okay. Coming on to HBE beta thalassemia. Now the HBE gene HBE is basically a G2A substitution in codon number 26 of the beta globin gene. So this mutation causes a structurally abnormal hemoglobin, and which leads to a decreased production of beta chains. So essentially, it behaves like a mild beta plus thalassemia, and this leads to a thalassemia intermediate. You can have HBE beta thalassemia clinically in 3 different presentations. Like you can have it as a mild, moderate, and severe. The severe is a transfusion dependent, whereas a mild and moderate may lead to a non-transfusion dependent thalassemia. So, which are the modifiers in this disease? It depends. Same as the beta thalassemia modifiers, you can have co-inheritance of alpha thalassemia. You can have increase in the fetal, the gamma chain productions, and tertiary modifiers are same as in beta thalassemia. Interestingly, the HBE beta thalassemia patients their disease will be modified even by age, because advancing age will lead to decreased production of erythropoietin and they may have a more severe anemia. Now coming on to thalassemia. So what are the modifiers in thalassemia? Thalassemia severe is incompatible with, right? The HbH disease again is caused by 128 different molecular defects. So these molecular defects may lead to loss of just one alpha gene or loss of both the alpha genes. Most of these mutations are deletions, and then again these deletions may be of different size. The commonest, the Southeast Asian deletion, it involves both the alpha genes but not the embryonic alpha genes, whereas the larger deletions, which will have a more severe phenotype, affect the embryonic genes as well. So the degree of alpha genes deletions will determine how severe is the HbH disease. Apart from these deletion genes, which are the commonest, you can also have non-deletional HbH disease, and 70 such mutations have been described. These are in fact more severe, and one which is the commonest among them, what we know as HbH constant split. The other modifiers is if you co-inherit beta globin gene mutations, that will lead to a milder phenotype again. And then you can have mutations affecting the alpha hemoglobin stabilizing protein, which will again ameliorate the disease severity. So this is the same table giving the tabular form what causes alpha thalassemia, the non-transfusion dependent. Okay, coming on to pathophysiology, as I said, it is ultimately the imbalance in the production of alpha and beta globin genes. These unbalanced hemoglobin, they precipitate, they undergo oxidation to form NADH and hemoglobins, which eventually separate the heme from globin. So basically, heme disintegrates from globin. This disintegrated heme, it releases free iron, which causes the reactive oxygen species, leads to oxygenation of the membrane proteins, structural membrane defects. Finally, the red cell senescence antigens like phosphatidylserine causes the premature cell death, leads to ineffective erythropoiesis, and if not that, then destruction in the peripheral circulation leading to hemolysis. So this is the basic pathophysiology of thalassemia, which is depicted very nicely in this table from the Thalassemia guidelines. You can see that the red cell pathology, because of the impaired alpha globin ratio, leads to ineffective erythropoiesis, hemolysis, which leads to anemia, iron overload, which leads to decreased oxygenation, and this is responsible for all the clinical manifestations of endocrinopathies, the thrombotic events, the bone deformities, osteoporosis, extramedullary hematopoiesis, hepatosplenomegaly. Okay. So I want to go back to our patient. So she came basically with a growth delay, which was depicted by her decrease in her height and her skeletal deformity, which was shown by her thalassemia cases. These children can also have osteoporosis leading to fractures also. They can have endocrine diseases leading to hypothyroidism, which she did not have, hypoparathyroidism, which is also responsible for bone disease. They have hypogonadotrophic hypogonadism. That is why her LH, FSH, estradiol was all low. This itself can lead to bone disease because loss of bone formation during puberty is dependent on the hormonal variation which happens at that age. So basically, the endocrine and the bone complications are a combination of anemia, ineffective erythropoiesis, iron overload, extramedullary hematopoiesis, hormonal and nutritional deficiencies. Coming on to the diagnosis of this patient. So basically, the first part of diagnosis is screening. The thalassemias are the commonest single gene diseases affecting the mankind, and it is inherited by the autosomal recessive mode. So it is very easily preventable, which is now, so many countries have conquered this disease. So basically, we need to have a lot of governmental support. We need to do a lot of public awareness, education, public surveillance, population screening. But as physicians working day to day in this field, we can also take part. Most important is the extended family screening. So if you diagnose a child with thalassemia, we must tell all the parents and the relatives, whoever is available, to screen all their relatives, the second, third, fourth, fifth cousins, especially pre-marital screening. If you have many of the hospitals have adopted doing a HPLC for the pregnant women as soon as they come for the first checkup. At that point of time, do a genetic counseling, a prenatal diagnosis, family planning. So this is the age to catch them. Then, of course, the universal screening of neonates is recommended for all the disorders to pick them up early and work them before they really become bad. So the most important thing is to improve the quality and life and management of the affected patients. So effective screening is the most important thing. We have seen the epidemiology, so we know the classical belts of these immunodeficiencies. But in today's world, there's so much of people are shifting to all the different parts of the world. So even the Northern Americas, the Europe, northern parts of the world, where actually the thalassemias were unknown, even they have a lot of incidents now of immunodeficiencies. So in fact, the state of California has a very good newborn screening program. And in fact, their data is really very robust on these immunodeficiencies. Coming on to principles of management, Shruti is going to talk about it, but the main things of management is the transfusion therapy, chelation, splenectomy, introducing the HbF-inducing agents, monitoring is the cornerstone, and then treatment and prevention of complications. Thank you very much.
Thank you, Dr. Vibha, for that wonderful overview of pathophysiology and signposting to the TIF guidelines, which all trainees, please, before your exams, must read at least the important recommendations, at least the salient points. And Dr. Vibha has very nicely signposted you to the relevant ones for NTDT. If I could now request you to stop sharing screen. Thank you. And invite Dr. Shruti to please move on to the next part of this session, which is the management and new frontiers in non-transfusion dependent thalassemia.
Good evening, everyone. Vanna, is my slide visible?
Yes, visible and moving.
Yeah, thank you, dear. So first of all, I would like to thank all of you for doing this program and bringing the monthly teaching back. And thank you, Dr. Vibha, for that nice introduction. So when we talk of management of patients with non-transfusion dependent thalassemia, I'll try to take you through a journey where we have learned how the patients with non-transfusion dependent thalassemia behave, and from there we actually get the clues about how to manage these patients, right? So non-transfusion dependent thalassemia, as Dr. Vibha has told you, is a group of disorders where patients do not need regular transfusion. But as you can see, there is a wide variation in their clinical manifestations, leading to a wide variation in the management. Now, about 10 years back, the old classification of thalassemia intermedia and thalassemia major was actually given away, and a more clinically relevant classification of non-transfusion dependent thalassemia versus transfusion dependent thalassemia came into place to make it more easy, for the guidelines, for inclusion into the trials, and make it easier to manage. Although there may be some, puzzling patients where we may have some confusion. Patients who are non-transfused or occasionally transfused are fine, but those who are frequently transfused may be labeled as neo-TDT if this transfusion dependence is long-term. Whereas if you're doing a transfusion for a short term, like in this child, which Dr. Vibha had, Dr. Revati had presented to, accelerate the growth and puberty, that patient may not be labeled as neo-transfusion dependent thalassemia. Whereas on the other side, now we have patients with TDT who have either been cured by using some curative treatment, so they would be labeled as ex-TDT. And there are patients who are now on the novel therapies where they have reduced transfusion requirement. Hence, they are called intermittently transfused TDT patients. Now, to understand, how patients with transfusion-dependent thalassemia behave, this was one of the first studies that I came across, and this showed the effect of age, advancing age, on the clinical manifestations. And amongst a group of 584 patients across 6 centers in Middle East and Europe, there were 120 treatment-naive patients. That means they never received transfusion, no hydroxyurea, no chelation. So these patients were studied, and the effect of age on various morbidities were elucidated. In this group of patients, the mean age was about 21 years, the average hemoglobin of about 7, and serum ferritin of about 610. Now, from this study, the authors had concluded that as the age increased, there was a fall in the hemoglobin level, increase in serum ferritin level, and that was associated with an increase in all the comorbidities that Dr. Vibha had just enumerated. Now, after this, there was another study from the same group of researchers which came and which studied the effect of hemoglobin level in treatment-naive patients. And in this study, there were about 63 patients with mean age of 31. Mean HB in this group of patients was 8.9. But amongst this, if you see about 65, that means 2/3 of the patient had at least one comorbidity, and nearly half, 44% patients had multiple comorbidities. And what this study showed us was that low hemoglobin meant high level of incidence of morbidities. HB of less than, patients who had HB of less than 7, all of them had morbidities, and patients who had HB of more than 10, none of them. So it's the hemoglobin which is an important indicator, and with every increase in hemoglobin by 1 gram per deciliter, the odds ratio of developing comorbidities was 0.29, so it decreased. And the hemoglobin was found to be inversely proportional to the ferritin levels in this group of patients. And then finally came the landmark study, how patients with non-transfusion dependent thalassemia behave while they were on treatment. Like these two studies took only treatment-naive patients. So in this, we took the researchers, screened about 584 patients from 6 comprehensive cancer care centers with 25.4 years of mean age. And you see the complications. The most common complications were osteoporosis, extramedullary hematopoiesis, hypogonadism, thrombosis. And then they studied the effect of the treatment modalities on the development of these complications. And amongst all, the 2 major important factors were age. As the age increased, the chances of a person with NTDT developing complications increased, and splenectomy, which was done for almost all NTDT patients about 10 years back, was associated with increased risk of morbidities, except for extramedullary hematopoiesis. So when we talk of management of non-transfusion dependent thalassemia, as Dr. Vibha showed in her last slide, we talk of transfusion, we talk of iron chelation, we talk of monitoring for complications, and then there are things like splenectomy, hemoglobin F inducers, and the novel agents which are now being added to the armamentarium. Now coming to blood transfusion. Now I'll keep going back to the optimal care study to understand, why are we doing this transfusion, in which conditions we want to go for a blood transfusion. So from the optimal care study, what came out was that transfusion was protective for almost most complications, except for those related to the iron overload. So what we saw that transfusion decreased the incidence of extramedullary hematopoiesis, hypertension, heart failure, thrombosis, cholelithiasis, but increased the chances of a person developing abnormal LFTs, hypogonadism, and osteoporosis. So, if transfusion therapy is so good that, a person gets rid of extramedullary hematopoiesis, pulmonary hypertension, thrombosis, why we do not transfuse all of our patients? This is because of considerable risk. A transfusion is associated with increased incidence of iron overload and the complications associated with iron overload. There is a high risk of alloimmunization. Remember, these patients who are started on a transfusion regimen later have a high chances of developing alloimmunization, and it may hamper their quality of life. Somebody who's not used to getting regular transfusion may not feel so good. So when we talk of transfusion, the transfusions can be done occasionally, that is during the periods of stress, when the hemoglobin drops, or there is a surgery during periods of infection, or for frequent transfusions can be done for some duration. Like in the patient which was shown, this patient had growth failure and failure of secondary sexual development. So this patient can be started on a transfusion regimen and then monitor the growth. And at the end of 6 months, we can again reevaluate the need of transfusion in such a patient. But there are other group of patients that need primary or secondary prevention, that is patients who have thrombotic or have cerebrovascular disease. They are at high risk. Patients who have developed pulmonary hypertension, patients with extramedullary hematopoietic pseudotumors, and those with resistant leg ulcers, which are causing an issue with their quality of life. Now, once you've decided to put a patient or a child on blood transfusion, remember the blood use should be less than 2 weeks old. It should be preferably leukoreduced and ABO and extended phenotype, as Revati has said, and with appropriate screening measure. Now, coming on to, we saw hemoglobin is the major, marker. The morbidities increase if the hemoglobin is low. So apart from transfusion, what we can do is hydroxyurea. So from the optimal care study, what we found that hydroxyurea was beneficial for prevention of all complications except for hypogonadism, because that is an adverse effect of hydroxyurea that we know. But we have had concerns about using hydroxyurea for such a long term in, small children over long durations, whether it can have long-term effects, long-term adverse effects on their growth, on their puberty, even second malignancy. So this was a long-term study where the duration of hydroxyurea exposure was about 18 years. And these were children who were started on hydroxyurea at about nearly 5 years of age. And with hydroxyurea, the average increase in hemoglobin that was found was about 1.3 grams per liter. And 82% of these patients showed a sustained transfusion dependence. But what is most important here is that only 33% patients had adverse effects. That too were mild and transient, and none of them required drug interval. So that gives us some more confidence, especially, especially along with the, literature that comes from sickle cell disease, that yes, hydroxyurea can be used for long periods in patients with NTDT. Now, once you've decided, you have to start hydroxyurea. The starting dose is about 10 milligrams per kg per day. Remember to keep the child on folic acid supplementation. If the child is tolerating hydroxyurea, increase by 3 to 5 milligrams per kg per day every 8 weeks to the maximum tolerated dose, but do not cross 20 milligrams. And the response evaluation can be done at 3 and 6 months. The response, the hemoglobin should increase by at least 1 gram per deciliter at the end of 6 months. And if that has not been achieved, it's the time to take the child off hydroxyurea. And for patients who will be continued on hydroxyurea, we need to keep reassessing at the end of 12 months and 24 months and henceforth. Apart from hemoglobin, we can also look at some other parameters like growth, functional status, quality of life, and other comorbidities when evaluating the response to hydroxyurea. But remember, do not use hydroxyurea in patients who are planning a family, those with hepatic and renal failure. Now, once you put a patient on hydroxyurea, the first 3 months, the monitoring is frequent. It's every 2 weeks. You have to monitor CPC, LFT, and RFTs. After that, it can be done every 1 month. And gonadal function, as and when it is needed, we can evaluate. For splenectomy, as I already told you from the optimal care study, we found splenectomy was associated with increased risk of all comorbidities except for extramedullary hematopoiesis. So now, with that information, we really need to consider whether we should splenectomize our patients, NTDT patients, or not. So as of now, as per the NTDT guidelines, we have to reserve splenectomy for these few conditions, that is worsening anemia leading to poor growth and development when transfusion or chelation therapy is not possible. If that is possible, then that's a better, course of action. Hypersplenism. Hypersplenism, when leukopenia or thrombocytopenia is leading to clinical problems. Splenomegaly leading to left quadrant pain, early satiety, or massive splenomegaly. And do not forget the immunization and penicillin prophylaxis if in case you have to splenectomize a patient with NTDT. Now, we've heard so much, splenectomy is bad. So can we do something to prevent splenectomy? So there have been a couple of studies about ruxolitinib. The first phase 2 study came from Dr. Tahir, which was a co-treatment of about 30 weeks followed by an extension. It showed an, decrease in the spleen size. Although, the hemoglobin parameter did not improve. That's why the authors decided not to go ahead with further studies with ruxolitinib. But now we have some data from India where Dr. Amita Mahajan and her group from Apollo have used, ruxolitinib in 4 patients with increased spleen, and it should consist, over a period of 6 months, there was an increase in hemoglobin, platelet count, the absolute neutrophil count with decrease in spleen size. But remember, all these patients, both these studies were patients with transfusion-dependent thalassemia who developed hypersplenism. But can this be used in NTDT remains a question, and we need to answer it with probably future studies. Just a word about gallstones, that if you're going in for splenectomy, remember to look at the gallstones, gallbladder for the gallstones, and if there is evidence, it should be taken out at the same go. Coming on to iron chelation, which is, the next important part of management of any patient with thalassemia. Now, as far as iron, before, the optimal care study came, we had this study called Orient study, which assessed the effect of serum ferritin on the morbidities. And in this study, there were 52 patients with beta thalassemia intermedia, mean age of 24. And the retrospective review over 11 years had shown that serum ferritin increased from mean of 503 to 1209 over a period of 11 years. And when, assessing the morbidity-free survival, it was seen that patients who have serum ferritin of less than 300 had almost 100% morbidity-free survival, whereas those with more than 800 by 10 years had nil morbidity-free survival. And again, just showing it again that patients who had any type of morbidities had much higher serum ferritin when compared to patients who did not. And, patients with less than 300 did not have any comorbidity, and the risk of comorbidity is higher when patients had serum ferritin of more than 800. So the first randomized controlled trial about iron chelation in transfusion-dependent thalassemia was the Thalassemia study, where, it was about 166 patients were included. The starting dose of deferasirox was, in one group, it was 5, in another group, it was 10, and it was compared with the same dose of placebo, although for the assessment of response, the placebos were grouped together. So they were, at the time of assessment, there were 3 groups, deferasirox 5 mg, deferasirox 10 mg, and then the placebo group. And at the end of 52 weeks, what we say that the absolute decrease in liver iron concentration is there with 5 and 10. The decrease is better. The fall in LIC is better with 10 mg per kg. And in fact, in patients on placebo, the LIC had actually increased at the end of 1 year. Similar changes were seen with serum ferritin. And during this study, there was a correlation, we tried to study the correlation between the LIC and serum ferritin, and the correlation was, coefficient was found to be 0.639, which showed some moderate correlation between the 2 parameters. Coming to the adverse effects were comparable. All the lab and the clinical adverse effects were comparable between the 2 groups, and most were mild to moderate severity and resolved without discontinuation of any treatment. Now, the extension of this study, we realized that, serum ferritin is an important parameter, and bringing down the iron concentration in the body does good to our patients with NTDT. So the extension of Thalassemia study was continued, and it is called a Thetis study. And in this, the chelation was started at 10 mg per kg, but was again modified. The chelation was intensified if the patient had higher, liver iron concentration more than 7. So we started with 10. If the liver iron concentration was between 5 to 7, it was continued at 10 at the end of 4 weeks. If the liver iron concentration was between 7 to 15, the dose was increased to 15. And if the LIC was more than 15, the deferasirox dose was increased to 20 milligrams per kg per day. And again, at the end of 6 months, a reassessment was done with the help of liver iron concentration assessment. And then the dose was the dose in patients who still had iron overload or less than 25% reduction from the baseline, the dose was actually increased to 30 milligrams per kg per day. Now, with this, at the end of the study, there was a decrease in mean LIC from 15 to 8, and similarly, serum ferritin decreased from 1,000 to about 600. So this made the basis of the current algorithm, the proposed algorithm for management of iron overload in NTDT given by the NTDT guidelines, where if the serum ferritin and LIC are, within 5 to 7, then the dose is continued at 10, and it can be increased to 30 in patients who have severe iron overload or a very high serum ferritin. Now, talking about other chelators, as far as desferrioxamine and deferiprone are concerned, there are no randomized studies, and this cannot be recommended as of now. But yes, there are few small studies where it has been used in patients who could not tolerate deferasirox or before the deferasirox era. So this has been used, decreases ferritin, decreases iron overload, but it cannot be recommended. The current only recommended drug is deferasirox. Now, moving on to some of the complications, I'll just restrict to the, the complication, the risk factors, and how to manage them or how to screen for them. Now, thrombosis. Thrombosis is, is one parameter which actually differentiates thalassemia intermedia from thalassemia major. Amongst a cohort of about 8,800 patients in the Middle East, the incidence of thrombosis in patients with NTDT was found to be about 4.3 times the incidence in transfusion-dependent thalassemia. And as we can see, the venous thrombosis is more common in NTDT, and the arterial is more common in TDT. Now, the risk factors for TDT, for thrombosis, as we saw in the optimal care study, splenectomy, patients who have not been transfused, so have a low hemoglobin, features of hemolysis, which leads to ineffective erythropoiesis, higher platelet count leading to platelet aggregation, iron overload, or pulmonary hypertension. So can we prevent it? We don't have any routine, there is no role of any routine screening, but yes, we can add aspirin in patients who have splenectomized and have platelet count of more than 5 lakhs, sorry. And if there is a history of thromboembolism, we can discuss, or a patient is at high risk of thrombosis, then we can put the child on a transfusion therapy for primary or secondary prevention. Hydroxyurea and iron chelation, there is no robust data to say it prevents thrombosis, although it has been shown to be beneficial when it was added for some, for other things, like for iron overload, hydroxyurea was added to increase hemoglobin. And if a patient develops thrombosis, then the management would be as per the standard guidelines. Moving to pulmonary hypertension, the risk factors are actually similar to the thrombosis, splenectomy, low HP, iron overload, high evidence of ineffective erythropoiesis in the form of nucleated RBCs, and history of thrombosis. Now, how do we diagnose? So a patient with NTDT should have an annual echocardiography to look for the tricuspid valve regurgitant velocity. If the regurgitant velocity is more than 2.5 meters per second in a symptomatic patient or 3.2 in an asymptomatic patient, there is a high likelihood of pulmonary hypertension, and it can be confirmed by right heart catheterization. Management, we saw from the optimal care that hydroxyurea, blood transfusion are beneficial in patients with pulmonary hypertension. We can use sildenafil, which is a vasodilator, control the iron overload status, and anticoagulation, like antiplatelet therapy, like in thrombosis. Now, leg ulcers is another troubling issue that happens in patients with NTDT. So they should have a routine skin examination when they come for their visit. We can advise limb elevation for a couple of hours, especially at night. Some topical antibiotics, occlusive dressings. A patient who's having some, refractory leg ulcers, troublesome leg ulcers, and we can put them on a short-term blood transfusion therapy or hydroxyurea. Some vasodilators, the oxygen chamber, platelet-derived growth factor, and anticoagulation may be helpful. And finally, if nothing is working, then we need to call in our plastic surgery colleagues and ask for a skin grafting. Now, other, major, important complication that can lead to long-term neurological sequelae is extramedullary pseudotumors. So we need to assess the deterioration. In cases of mild to moderate, we can do, hydroxyurea, we can do, blood transfusion transiently or low-dose radiotherapy. Whereas in patients with severe neurological, deterioration, we need to go for urgent, laminectomy to, save the limbs. And a word about newer agents, all of these, luspatercept, all of them have heard, but I just, read, I think last week that I think the company has actually withdrawn the application submitted to the FDA. Mitavipitat has been used for pyruvate kinase deficiency patients, and there's a trial which is going on. There's another trial with oral ferroportin inhibitor, mini hepcidins, and gene therapy. So these could be agents we could use in future, but right now, we have to choose from what available parameters we have. Now, a very important question is role of bone marrow transplant. I think that's one. For the transfusion dependent thalassemia, all of us are very clear, you have a match, go for it, right? But for a non-transfusion dependent thalassemia, would you or would you not go for a transplant? Now, that's a tricky question. But, over a period of time, we've seen that patients with non-transfusion dependent thalassemia actually are more unpredictable. The complications are much more severe. So maybe, right, if a patient, in early childhood, like 7 to 10 years or early, adolescence develops increasing requirement or iron overload, then we may consider, although, we just need to wait for, more results, more trials are needed to say whether it improves the quality of life, and whether it's the risk worth taking. So, I mean, that's something something to ponder upon, and I would look upon, all the seniors in the group to help us through this question. And finally, I would, say that NTDT, again, there is no set rule like TDT. You have set parameters, but yes, there are studies, there are guidelines to help us. And of course, within the PHO group, we can sit down and discuss such cases, which will help us cater to our patients in a better way. Thank you with that. And I would hand over the mic to proceedings to Vanna.
Thank you, Shruti, for that wonderful evidence-based overview and pointers to management in NTDT. Thank you very much. I'd just like to put out the questions on the chat. Many of them have already been answered, but for the benefit of the trainees, I'll just go over them again. The question we had asked was, is the risk of thrombosis higher in thalassemia intermedia, and is it post-splenectomy? And what is the explanation for that? So as we have shown undisputedly in the trials, that is true. And why is it so? The question's been answered on the group, and I'll just read it out. It's because of the deformed red cells not being taken off by the spleen, causing endothelial damage, reduced nitric oxide, and causing thrombosis. And also senior faculty sharing that, previously, maybe 10, 15, 20 years ago, every NTDT patient got a splenectomy, whereas we hardly do that these days because we know that is detrimental to their state of health. There was another question, and if I may ask you, Shruti, to take this one. Commenting on the incidence of, we know that the incidence of pulmonary complications in thal intermedia NTDT are higher. Do we see a similar sort of thing in other chronic hemolytic disorders, or is this something that is specific to NTDT?
Vanna, I think when it comes to pulmonary issues, NTDT becomes the epitome, right? As far as other chronic hemolytic anemias are concerned, I think pyruvate kinase, chronic pyruvate kinase deficiency they kind of present like NTDTs, and they need these chronic transfusions. They have hemolysis, so similar should be there. But yes, I would like to go back and check the literature on that.
Absolutely. I mean, the only thing that came to my mind was sickle cell disease, because
Yes,
sickle cell is
sickle
also
cell.
a chronic hemolytic anemia, and the neurological complications, particularly the stroke complications, but we're talking about arterial, of course, we're not talking about venous
We are
thrombosis,
not.
is much higher in sickle. Nearly 10% of those not transfused with high MCA velocity. So we know that.
Conditions,
Anjana,
so the
this is
condition
Dr.
which
Warrior.
go,
Can I make a
Dr.
comment?
Warrior. Yes.
Yes, Dr.
Yeah,
Warrior, good evening.
Hi guys, how are you?
Sure,
As
sir.
sickle cell anemia, especially as they grow older and live, many of them have got pulmonary complications. So it's really interesting. As we pass them to adult service, many of them get pulmonary hypertension and complications. So really, it's a big issue in sickle cell disease now. Yeah.
So what I thought was the conditions which need chronic blood transfusion therapy, they will have a slightly lesser pulmonary hypertension, whereas the diseases which may require occasional or no transfusions will go into the complication of pulmonary hypertension as the age advances. And there can be secondary things like, as age advances, smoking, or these things are going to offset. So right at the outset, we need to make those lifestyle changes.
So thank you, Dr. Vibha. So important point there for trainees to note that lifestyle, lifestyle advice to these children or young adults is as important as looking after their disorder. Whilst looking at the dose of hydroxyurea, etc., is important, and talking to the parents is important. Genetic counseling, also moving these patients on. They have to live with this disease for the rest of their lives. So moving these patients on, advising them about lifestyles, decades are really important points to note, particularly in adolescents when you see them in the OPD occasionally. I'll just the questions. So there was one more question about if serum ferritin kept less than 500, can we guarantee that the cardiac or the hepatic complications due to iron overload will not occur? So I'm not sure that the answer to that is yes.
The cardiac
but, I'll let you...
complications do not. That's something I think I missed out. The cardiac complications actually do not. The cardiac iron overload does not happen in non-transfusion dependent thalassemia, right? We need to understand the mechanism of iron overload in NTDT is completely different from mechanism of iron overload in TDT. In TDT, the main source of iron is blood transfusion that you're giving, right? And in NTDT, the source is actually not blood transfusion. It is the intestinal obstruction, absorption of iron that is happening. So it is mainly, concentrated in the liver and the hepatobiliary system, and it doesn't go to the heart. So we really do not need routine cardiac screening as of now. We need to do cardiac screening for pulmonary hypertension, but not for iron overload. And as far as, serum ferritin is concerned, we just showed you that this long-term optimal care study and the Orient study showed that if the serum ferritin is kept below 300, none of the patients developed cardiac and developed any comorbidity for that matter.
So Shruti, Dr. Warrior.
Yeah.
Yes, sir.
So
that's okay. Sorry.
Oral hepcidin or the iron absorption prevention helping with more than thalassemia major? If you prevent iron absorption by some mechanism, will that help?
I'm so sorry, sir. I couldn't get you. Can you please?
I said
repeat?
if you can use any drugs to prevent oral absorption of iron, will that help in these people?
Oral absorption of iron, so the guidelines say tea consumption is, recommended for patients with NTDT. And probably, yes, we said we could be having, some drugs which can, alter the hepcidin mechanism and decrease absorption. That's something we are looking forward to in future to, reduce iron overload in patients with NTDT.
So having said that, the ferritin, the serum ferritin and the tissue overload, whether it is the liver or heart, they don't really go hand in hand. And this mismatch increases, as the ferritins increase. So that is true for TB, the transfusion dependent, absolutely. So like if you use the word guarantee, we cannot guarantee, but the thing is that the incidence is less. Yeah.
And one more thing, when you were talking about the heart complication, it's to be remembered that in NTDT, it's not so much of ventricular dysfunction what you get in TDT, it's more of a PH, which is related to a multiple other factors, and serum ferritin is one of the very small factors. It's related to basically the pathophysiology which Shruti had given initially, which is responsible for the cardiac dysfunction which results in it. So you can't, just say that if you maintain the ferritin load, this will not occur. So NTDT is actually maybe 20 times more complex than thalassemia major, because there's a lot of things which one still does not know about NTDT, especially the pathophysiology related to your red cells, your platelets, your prothrombotic state, even your leukocytes and all are known to become sticky. So it's from a pathogenetic point of view, it's an extremely complex disease. So that I just wanted to add this bit. Yeah. And of course, Dr. Warrior, since we have you here, I think we'd love to have your pearls of wisdom on this.
So, unfortunately, thalassemia is so little in our practice. We have mostly sickle cell, and unfortunately, sickle cell anemia, even iron overload is different from thalassemia. So we rarely have much problem, very much different from thalassemia, because iron absorption is not there. So my experience
is totally different.
Most of it is sickle cell. So thousands of them, but not thalassemia. Thank
No,
you.
it doesn't matter. So thank you.
I totally
Thank you,
agree with Dr.
seniors.
Trehan. Yeah, so I just wanted to say just the mechanism of osteoporosis and bone disease in NTDT is so complex. I mean, the iron which gets absorbed in the osteoid, decreases the osteoid formation, it increases the osteoclastic activity. So it's really so complex in this case. So that is the entire pathophysiology of the bone.
I have a question for Shruti. Shruti, does anybody try growth hormone for these people?
Growth hormone, sir?
Yeah.
I think so. If somebody is failing on and not thriving well, the first thing would be to correct the hemoglobin and put a child on transfusions, and then along with that, yes, do the entire endocrine workup. And if with the transfusion it's not increasing, then yes, we can consider growth hormones in that scenario.
Growth hormone and even sex hormones like estrogens or testosterone.
Yes, so we do that. To answer your question, that depending on what the endocrinologist, but first, of course, is the sexual maturity rate, which has to be taken into account. And the other thing is giving growth hormone is extremely expensive. So it comes to more than 1 to 1.5 lakh rupees per month for a teenage child. And since it has to be given for a prolonged period of time, it's not an easy thing to do. And I think this is very important for the trainees to understand also, when very often we discuss new drugs, you read new drugs, but do not advise them to families, especially when you cannot afford, they cannot afford it. It is our duty towards the families also not to give them advice which is not, to give it very, very carefully for advice which is not with easy reach. And fortunately, I think we are very, very lucky that for the past few years, the government is funding a very high percentage of medications for thalassemia as well as NTDT. So we should be extremely careful when we are counseling a patient also, because if you tell them all fancy new medicines which are like available in America, it's not fair for the patient as well as for us when we are telling them things which we cannot get. So that's just an offside thing, because you're all trainees, and this is something important for us to know, because people these days read on social media, they read in the newspaper, etc. But we have to inform a patient about the evidence behind the medication, and whether a lot of times there are trials going on. So it's our duty to tell the patient that this drug is still in trial and we cannot just use it. Sorry, that was just offhand, but I thought it was a little.
Ma'am, it is important. I just wanted to add on to that about 500 thalassemia patients under follow-up. There's only one patient who's on growth hormone, mainly because of affordability reasons. So, my experience with growth hormone is it's more theoretical rather than practical.
So all the discussion seems to be amongst all the, older senior people in the forum, and the younger people are quiet, which is not
Dr.
why we are
Siaram
having
has
these
raised
meetings.
his hand, ma'am. We can ask
Yeah.
him.
Yeah, please, Siaram, tell us.
Yes, ma'am. Good evening. So my two query, ma'am. One is the ferritin and iron correlation in the transfusion dependent and non-transfusion dependent thalassemia is the same line or it is different? And the another is the iron chelator of choice in the especially in the non-transfusion dependent thalassemia, especially if cardiac involvement is less.
Shruti, over to you.
You're muted, Shruti.
Yeah. So sorry. So, Dr. Siaram, I think for your second question, I had shown it in my presentation that the only chelator that is recommended as of now for patients with non-transfusion dependent thalassemia is Depresirox. The dosage is starting dose 10 milligrams per kg per day. You can go up to maximum of 30. We do not reach up to 40 like we do in patients with TDT. And that too, it is guided by serum ferritin and probably if you can do an LIC. Now, coming to correlation between serum ferritin and LIC, we know that in TDT, the tissue ion overload, whether liver or cardiac, does not really correlate well with the serum ferritin. And in NTDT, I had shown in one of the graphs from the Orient study that the correlation factor between serum ferritin and LIC was only 0.69. So we say 1 is a good correlation. Less than 1 is less, so 0.63 would come somewhere in a moderate correlation. So we really cannot judge, but we have, these cutoffs in NTDT that less than 300 somehow, serum ferritin of less than 300 correlates with a LIC of less than 5, So probably that correlation in NTDT is much better because there are, set categories that have been given by such a long-term studies. Vibha ma'am, if you want to add anything.
No, I think, yeah, that's what we said. But as the ferritins come down, the correlation becomes better and better. And as it goes up, it becomes diverse. And we only had something experience in TDT to match this. So NTDT, the numbers are smaller, they are not well recognized. They don't really come into the mainstream. So they are a very ill-defined heterogeneous population. Not just in India, but all over the world.
Okay. Thank you very much, Dr. Vibha, Dr. Shruti, Dr. Revati, for this wonderful session. And thank you, participants, trainees, and faculty across the country for joining it and making it a success. Dr. Warrior, special thanks to you. And also wishing all our trainees and faculty across the country happy Onam and to enjoy the rest of the evening. And just before we sign off, I'd like to talk about the next program. The next program is going to be on the second Thursday of October, which is 13th of October at 7 p.m. And the topic is risk stratified management of pediatric Burkitt lymphoma. So exciting topic there. So the Banaras Hindu University colleagues, Dr. Vinita and her trainees will do the first part of the session, and Dr. Sanjeev Khera from Research and Referral New Delhi will do the expert session. So requesting you all to please mark the date and time and log in, and again continue to make the program a grand success. Ma'am, Dr. Amita, if any other closing comments, otherwise we can finish.
No, it's been wonderful. And we can see that we started with 70 trainees. We're down to 39, which means everybody has gone for dinner, except us. So all trainees, it would be appreciated if you could, give in your feedbacks. These sessions are for you. So we want them to be of use to everyone and not, just for just for you to kind of go to stay. We enjoy them and we'd like you to enjoy them as well, right? And good night and see you all next month.
Get your thanks, Vandana and Peter, for coordinating this. We had an excellent time preparing and doing it.